Hey everyone, and welcome to this explainer. Today, we are going to decode the architectural blueprint of the human body and look at exactly what happens when that genetics blueprint goes fundamentally wrong. Honestly, if you've ever wondered how biological tissues can withstand a literal lifetime of tension, weight, and movement without just falling apart, you are absolutely in the right place.
Let's kick things off with a pretty wild question. Imagine the microscopic scaffolding holding your entire body together. What actually happens when those molecular steel wires snap, fray, or just stretch way beyond their limits? Well, the answers are all hidden in the clinical genetics of connective tissue disorders. It's a really fascinating, complex web of conditions that impacts everything from your bones right down to your blood vessels.
Here's our roadmap for today. Consider this your ultimate exam prep guide. We're going to start with the baseline scaffolding, then move through the big hallmark disorders, osteogenesis imperfecta, Ehlers-Danlos, and Marfan syndromes. Finally, we'll wrap up with a master cheat sheet to help you differentiate all of them perfectly. All right, Section 1, the body's scaffolding. Let's look closely at those molecular steel wires that make human structure possible.
To really grasp why these diseases happen, we have to start at the baseline structure. Fibrillar collagen is this incredibly strong structural protein that forms a rigid triple helix. And get this, gram for gram, it provides a tensile strength that's actually comparable to steel wires. So when you think of human durability, you're basically thinking of collagen.
Now, building this superstructure is a really precise, multi-step process. Just look at step 1 for a second. Hydroxylation in the endoplasmic reticulum is completely dependent on vitamin C. This is exactly where ascorbic acid is just an absolute requirement. Without it, the collagen literally just unfolds and degrades. And that catastrophic breakdown is exactly what we know clinically as scurvy. There's also a strict non-negotiable biochemical rule at play here. Glycine absolutely has to be at every third position in the amino acid chain. Why? Well, because glycine is the smallest amino acid, and it's the only one that can fit into the incredibly tight, sterically restricted interior of that triple helix. If you swap out that tiny glycine for literally any bulkier amino acid, boom, you get a steric clash. That delays folding, causes severe ER stress, and sets off a massive systemic failure in the body's matrix.
Which brings us nicely to Section 2, osteogenesis imperfecta, better known as brittle bone disease. Let's see what happens when those structural beams fail. It's actually wild how concentrated the genetic cause is here. A massive 80 to 85% of all OI cases stem from mutations in just two specific genes, COL1A1 or COL1A2. These are the genes responsible for type 1 collagen, and when they mutate, it sets the stage for those massive architectural collapses we see in patients. These different genetic failures build the foundation for what we call the Silence classification system. Notice the huge difference here. Type I just reduces the quantity of collagen, but the structure itself is fine, so it's relatively mild, and patients can be active adults. But compare that to type 2. Here you have a structural mutation acting as a dominant negative effect. It essentially poisons the normal chains. This causes a lethal condition with severe in utero fractures and beaded ribs. Then you have type 3, which sits in the severe but non-lethal category, and is famously characterized by progressive deformities and those distinctive popcorn metaphyses you'll see on an X-ray.
Okay, pause right here because this is a super high-yield detail for your exams. Look at the stark color contrast in the eyes. Dominant forms of OI, like types I and 2, typically present with distinctly blue sclera. But on the flip side, the recessive forms, driven by processing defects, paradoxically present with distinctly white sclera. Keep that little contrast trick in your back pocket for sure.
But hey, remember that OI isn't just about bone fractures. It's a completely systemic issue. The bone isn't just weak, it's actually paradoxically hypermineralized, which is why it snaps like chalk rather than bending. You'll also see dentinogenesis imperfecta, where primary teeth just crumble, along with hearing loss that starts conductive and becomes mixed. But here's the most critical takeaway. Pulmonary disease is actually the leading cause of death for these patients, driven by chest wall deformities and intrinsic lung collagen defects.
Moving right along to Section 3, Ehlers-Danlos syndromes. Here, we shift from brittle bones to skin and vessels that completely lose their snap.
The Ehlers-Danlos spectrum can definitely be complex, but all types generally share skin hyperextensibility and joint hypermobility. Knowing the specific types, though, that can literally save lives. Classic EDS is famous for velvety skin and widened atrophic piperaceous scarring. Then there's vascular EDS, involving COL3A1. That targets type 3 collagen in blood vessels, making it incredibly dangerous.
Lastly, hypermobile EDS presents with severe joint hypermobility and chronic pain, but frustratingly, we still don't have a known genetic marker for it. There's a massive clinical contrast here that you really need to respect in practice. Vascular EDS requires extreme caution. Even routine invasive procedures can be deadly because of the risk of life-threatening arterial or bowel ruptures. These patients absolutely need emergency medic alert cards. On the other hand, hypermobile EDS is the most common type you'll actually see in the clinic, but since there's no identified gene yet, it's entirely a clinical diagnosis. You basically have to rule everything else out first. All right, on to Section 4, Marfan and Loeys-Dietz syndromes. This is exactly what it looks like when the body's suspension cables start fraying.
Marfan syndrome pops up pretty often, affecting about 1 in 3,000 births. It's caused by a mutation in the FBN1 gene, which codes for fibrillin-1. This defect weakens the microfibrils and unleashes excess TGF-beta. It typically hits 3 major systems. Skeletally, you've got the tall stature and arachnodactyly, those classic long spider-like fingers. Ocularly, you see ectopial lentis, where the lens actually dislocates upwards and temporally. And cardiovascularly, those frayed microfibrils drive really dangerous, life-threatening aortic root dilation.
Now, here is a classic exam trap, so let's use a quick mnemonic to separate Marfan from its dangerous look-alike, Loeys-Dietz syndrome. Just remember, Loeys does something different. They have widely spaced eyes, a cleft palate or a split, bifid uvula, and widespread arterial tortuosity that goes way beyond just the aortic root. And the absolute kicker, they do not have ectopia lentis. Their eye lenses stay perfectly in place. Section 5, Cartilage and Kidney Disorders. Let's check out some highly specialized scaffolding in the body. Here we're dealing with localized matrix defects. Stickler syndrome is all about mutations in type 2 collagen, which is huge in cartilage in the eye, leading to cleft palates, hearing loss, and retinal detachments. And then we have achondroplasia. Get this, over 99% of cases come from one specific recurring gain-of-function mutation in the FGFR3 gene. This unregulated signal actually stops chondrocyte proliferation at the growth plate, which leads straight to that classic presentation of short-limbed dwarfism with a normal-sized trunk. And whatever you do, please don't forget type 4 collagen. This is the stuff forming the sheet-like networks in your basement membranes, especially in the kidneys, ears, and eyes. If you get mutations here, it creates the classic triad of Alport syndrome. It usually kicks off with blood in the urine, leading to progressive kidney failure, sensory neural hearing loss, and a really specific eye defect called anterior lenticonus. Finally, Section 6, the master disease differentiators. Let's pull the whole shebang together into one ultimate cheat sheet.
If you only remember one thing from today, commit this synthesized slide to memory. Look at how the bone, skin, and vascular features separate these conditions. Core defect is bone fragility with blue or white sclerae. That's osteogenesis imperfecta. Hallmark is crazy skin and joint hyperextensibility with normal eyes, but maybe dangerous arterial ruptures. You're dealing with Ehlers-Danlos. And if you've got a tall patient with dislocated lenses and a dilating aortic root, boom, Marfan syndrome. Knowing these pillars is literally what separates a good diagnostician from a great one.
So, to wrap up this explainer, I'm going to put you in the hot seat. Apply what we just talked about. Let's say a tall patient with a bifid uvula and widespread arterial tortuosity walks into your clinic. Based on those exact clues alone, do they have ectopia lentis? What's the diagnosis? And why are you absolutely confident their eye lenses are completely fine? Think back to the Loeys does something different rule. Thanks for hanging out with me today. Keep studying that scaffolding, and I'll catch you in the next explainer.